Thank you so much for everyone who's attending tonight. Pre-health shadowing is an international student-led, woman-led, minority-led nonprofit for medical advancement, and we provide shadowing opportunities to everyone worldwide. We do have closed captions for accommodations for students, and if you have any ideas of how pre-health shadowing can be more accessible, we would love to hear your ideas. If you have any ideas, you can email them to info@prehealthshadowing.com. Also, if you want to keep in touch with us, you can save our email so it bypasses the spam folder and you can hear about all of our amazing shadowing sessions coming up. We also have Instagram and TikTok, so you can keep up with us on our social media. So be sure to follow and like all of our stuff. And then we host students from all over the world. So we would love to hear where everyone is calling in from tonight. So if you want to post that in our chat, we would love to see where everyone is from. And then if you are interested in becoming part of pre-health shadowing, we are currently doing recruitment. So you can become a team member or you can become a volunteer, whichever fits best with your schedule. And we have all the information on our website. And here are some of the roles that we are currently recruiting for. So our IT department, we have fundraising, grants, video production, research, recruitment, diversity and inclusion, department head, and volunteers, and many more. There are descriptions about each position on our website as well. You also don't need to be a pre-health or pre-med student to join our program. So if you have friends who are studying finance or computer science, please send them our way because we would love to have them on our team as well. And then we also have a high school program, HTP. So that helps students who want to establish a pre-health, pre-med club on their high school campus. So if you're in high school and you want to have leadership opportunities, it's a great thing to look into. You can find more about that on our website at prehealthshadowing.com. And then we also would love to hear all of your opinions. So if you are interested in getting published, you can submit your writings on our website at prehealthshadowing.com/blog submissions. We love to host some of your thoughts, opinions, articles, research that you've done. So if you're interested, definitely consider that. And then since pre-health shadowing is a nonprofit, we would love if you could donate. So you can scan the QR code. But we also do understand that we are all students and money can be tight. We also just experienced a global pandemic. So if you are unable to donate, we totally understand, but we would also love for you to share this with your parents, your friends, your neighbors, anyone who you think would be able to donate. And then during our presentation, if you ever have any questions, feel free to type them in the chat. We will be asking questions at the end of this presentation. So if something comes up in the middle of a thought, just jot it down so you don't forget and we'll get to it at the end. Or if you want to save them all to the end, you can do that. And don't forget to post them in the chat so we can ask our wonderful professional. And then there is a post-shadowing assessment. It will be open once the presentation is over, so be sure to take good notes so you can pass that. The passing score is a 70%. And once you pass, you will get a certificate verifying your hours. And you can do all of that on our website at prehealthshadowing.com. And then we would love to see all of your amazing faces, so we're not just staring at little black boxes. So if you feel comfortable, please do turn your camera on. We'd love to see where you are and, get to know you a little more. And without further ado, I would love to introduce our professional who is going to talk to us about an amazing topic tonight.
All right, good evening, everyone. So my name is VanDercar. I am a forensic psychiatrist in Cleveland, Ohio. and I'm going to talk to you today about forensic psychiatry. You want to go to medical school and you're passionate about medicine. But once you get to medical school, you need to pick your specialty. And so I want to share with you my specialty, my subspecialty, forensic psychiatry. And that's what I'm going to talk a little bit about today, what it is, what it entails, what the day-to-day work is. Because I'm very lucky to love my job. I have a job that I enjoy going to every day that has a great work-life balance. I work 40 hours a week, no nights, no weekends. Every day is different. So let me tell you a little bit about what forensic psychiatry is. Share my screen here. All right. So forensic psychiatry, it's a subspecialty of psychiatry. It's basically the intersection of psychiatry and the law. There's lots of different legal contexts that forensic psychiatry involves. There is civil, criminal, correctional, regulatory, legislative matters, as well as some of the specialized clinical consultations. What does all that mean though, right? That's lots of big words describing this very particular niche subspecialty. So let me give you an example. One area of forensic psychiatry, the area that I predominantly work in, is competence to stand trial. Now, competence to stand trial is looking at someone's mental state, particularly someone who's been accused of a crime, and it's assessing whether their mental state, whether any mental illness that they have, is making it so that they're unable to stand trial. And assessing that, and if someone is unable to stand trial, treating it is one of the things that forensic psychiatrists do. So let's take an example. 28-year-old man, schizophrenia. Now, schizophrenia is a mental illness where people have psychosis, hearing voices, sometimes seeing things, delusions, their speech can be disorganized. And this gentleman is charged with felonious assault. In jail, not taking any medications, and is talking and is not making sense. Won't meet with his attorney, keeps pointing at his attorney and alleging that his attorney is a demon. If you were the lawyer, so step back for a second. If you were the lawyer, tell me yes or no in the chat. Do you think that you could work with this individual to help him to fight his case? Go ahead and type it in the chat box. I see a no. Right. But who makes that decision? And how do we make that decision? Ultimately, the judge is the one that makes the decision because it's a legal determination of whether someone is competent to stand trial or incompetent to stand trial. But a forensic psychiatrist or a forensic psychologist, those are the people that do the evaluation in order to evaluate whether someone has the mental illness that then makes them unable or incompetent to stand trial. And that evaluation is one of the types of things that forensic psychiatrists do. Another example would be a sanity evaluation. Now, competence looked at someone's mental illness right then and there. Can they fight their case? Insanity is looking at someone's mental illness at the time of the crime. Now, this is actually a rarely used thing in terms of how often it's successful. But what it would mean is that someone was so mentally ill at the time of the crime that they shouldn't be held criminally responsible. Typically, they end up being committed to a psychiatric facility for as long or longer than they would have been committed if they had been sent to prison. An example, 34-year-old with bipolar disorder. That's a disorder where people have highs and lows with their mood. They might be talking really, really fast or really, really depressed. Charged with murdering his mother. At the time of the offense, he was manic. That means he was really high up, hearing voices saying that he needed to kill her, or she would help the aliens to come and destroy the earth. Stabbed her 41 times, called the police to confess, When the police arrived, he's sitting in front of the body, smiling, saying that he saved the world. So the mix of facts is not based on a real case, but the pieces of facts are mixed together from various real cases. And so this individual might plead not guilty by reason of insanity. They're at the jail, and then they can be sent for a forensic psychiatrist or forensic psychologist to do a sanity evaluation, either one who is retained by the court system, by the defense, by the prosecutor, or sometimes they're independent and employed by the state. We're going to go into each of those in a lot more depth. That was just kind of a teaser about why forensic psychiatry is such a unique niche within medicine. So let me stop and let me tell you a little bit about myself. So I started off by doing undergrad. I did a bachelor's of science in biology with a minor in biomedical physics and a bachelor's of art in philosophy. After that, I went and I taught for a couple of years at Kaplan Test Prep, taught the MCAT, the LSAT, number of other different courses, did some teacher training, also worked as the clinic manager. Then in 2006, I went to law school. I practiced law for a couple of years. I worked at a pain management practice as their in-house counsel, as well as their risk manager. After a couple of years and watching the system, this was as the opiate crisis was beginning to develop, I wanted to go back and I wanted to go into policy. I wanted to go into medicine initially in order to go and make policy on medical issues. So I went to the University of Miami and I went to medical school. In my third year, I met a forensic psychiatrist, and she showed me this subspecialty that I didn't even know existed. And I decided that I wanted to go into forensic psychiatry. I picked my psychiatry residency based on the desire to ultimately pursue forensic psychiatry as a subspecialty. I moved to Cleveland, went to Case Western University Hospitals for my psychiatry residency. That's a 4-year process. And then I did my fellowship staying in Cleveland as well in forensic psychiatry. And then last year in August, I started at Northcoast Behavioral Healthcare, which is a state of Ohio psychiatric facility. It's around 220 beds. There's 10 units. Large percentage of it is forensic. And I co-lead one of the competency restoration units. Now, from a day-to-day perspective, this is what my day looks like. I start off at 8 o'clock in the morning. I come into the hospital, go through the double doors, go up to my office, and then I review the nursing notes from the night before. Most of my patients are on a competency restoration unit. This means that these are individuals who have been found by the court system to be incompetent to stand trial, kind of like the hypothetical that we talked about. And we have a set period of time, 30 days, 60 days, 6 months, a year, depending on how serious their criminal offense that they're alleged to have committed, because we don't know yet if they did it. There's just probable cause that we have to restore them through treatment and medications. I also do competency evaluations for somewhere between 3 to 5 patients at a time, inpatient competent stand trial evaluations. And we're going to talk about that a little bit more later. So when I get there in the morning, I review all the notes from the night before. 8:35, I sit down on my unit with the nurses, social workers, patient aides, and we discuss what happened since the day before. Any codes. Now, a code on a psychiatric unit is a little bit different than the typical code that you would see on a medical floor. Our codes tend to be people who are becoming very agitated. Maybe they're just getting started on their medications, or they're starting to decompensate and not do well, who were starting to become agitated and needed some additional support and assistance in order to bring themselves down to a level that was safer. 9 o'clock, I review records and write reports. So each week, I write somewhere between 1 to 4 reports. These are reports saying how people are doing with their restoration to competence, or for my evaluation cases, whether they're competent. My reports are between 10 and 35 pages. So that's a lot of writing. I tend to dictate most of them, and dictation is one of those things that when I got started, it was so hard. And then as I pushed myself to do it, it got much easier. So from 9 to 10:15, I'll review the records and dictate or write reports. 10:15, I go back to the unit and I meet with patients alongside the social workers, the nurses. 12 o'clock, lunch. 1 o'clock, I do evaluations of new patients or admissions of new patients. Around 3 o'clock, typically go back to reviewing records and writing reports. And then at 4:30, I head out for the day. And then once I leave for the day, I'm done. There's a different doctor that is there at night on call who handles any issues. There's also a different doctor that is there on the weekend in order to handle any issues that might come up. So how do you become a forensic psychiatrist? Well, first, there's medical school. So med school is 4 years. After that, there's psychiatry residency, which is a 4-year process. After that, you have the forensic psychiatry fellowship, which is 1 year. Now, medical school has different curriculums depending on where you go. So I'm going to describe how it was done at my medical school, University of Miami, when I was there. I think it has changed somewhat since I graduated in 2016. But when I was there, the first and second year were predominantly academic learning. You have cell biology, anatomy, genetics, histology, immunology, micro, and all of these different subjects that you're going through. Anatomy is a lab. It's also a class, but the rest of it is mostly listening to lectures, taking tests. It's a lot like undergrad, like organic chemistry, kind of. Third and fourth year is where the clerkship rotations, for the most part, tend to start. That's really an opportunity to figure out what you want to do, because picking your specialty in medical school, it's what's going to determine what you end up doing for the rest of your life. And you want to love it. You want to really like the choice that you make. And in order to facilitate that, that's why medical schools give you somewhere between 4 to 8 weeks in each of these different specialties, where you actually get to go and be on an internal medicine or a surgery or a family medicine, OBGYN, psychiatry ward. And you get to follow along and work with the residents providing clinical care so that you can decide which specialty fits your particular interests. And for me, it was psychiatry and forensic psychiatry. When I took my MCAT, I naively thought that it was going to be the last big test that I would ever take. So not true, just the beginning. So at the end of your second year, you have your USMLE step 1. Somewhere after your third or in your fourth year, you have the USMLE step 2. There's more to come, but those are another 2 set of big board exams or credentialing exams or just tests, kind of like the MCAT, that you have to take as you proceed along in your process to become a physician. Applying to the residency is going to go through the match process. Starting at the end of your third year, you need to already know which specialty you're going to go into. You need to be getting your letters of recommendation. And then in the fourth year, you're going to apply for residency programs. Now, this is done through the match system. You start by submitting applications to a large number of programs. You get interview invitations. You accept some of them, the ones that you're interested in. You go and you interview, and then you rank the programs. And it's a very interesting and unique system in that you rank the programs and they rank you. And then you wait for weeks. It's a stressful couple of weeks while you find out which one is the one that picked you on your match list. And wherever that might be, you're going to pick up and you're going to move there for residency. Now, psychiatry residency, again, different ones are structured in different ways. But in the first year, you have a series of different rotations. You have neurology, family medicine, emergency medicine, you have internal medicine, you have inpatient adult psychiatry, and you rotate through all of these different programs, acting just like one of their residents. For instance, if you're in the ER, you're running codes, you're doing procedures. They're giving you the skills so that when you are at a psychiatric facility and there's no internal medicine or emergency medicine doctor, and someone starts developing chest pain or says they can't breathe, you're able to manage the case well enough to get them to where they need to be, or until someone else who specializes in that specific field can come provide assistance. Second year of psychiatry residency, you're going to do more neurology, emergency psychiatry, inpatient child psychiatry, inpatient geriatric psychiatry, and inpatient adult psychiatry. In your third and fourth year, you have outpatient clinics, electives, and you have the opportunity to do some forensic experience. If you decide that you want to go into psychiatry and forensic psychiatry, you can actually begin to get involved in it much earlier on. At our program, we have people in their first year who join our interest group, and they start to come to some of our different meetings. They do some shadowing, sometimes even do some rotations so that they can get exposure to the field and begin to get articles, presentations, and other things to help build their CV and assist them for when they apply later on down to the Forensic Psychiatry Fellowship Program. And then there's another board exam. So typically after your first year, you do the USMLE 3, step 3. Okay, so you finish adult psychiatry residency. Some people also go into child, that's a different path. But either way, whether you went into child, which is typically 5 years, or you do adult psychiatry 4 years, you can then choose to pursue a fellowship. There's a variety of different fellowships in psychiatry. There's geriatrics, there's addiction, there's forensic psychiatry. The forensic psychiatry program is 1 year long. There's a series of different experiences that you do during that program. You have a court psychiatric clinic. That would be a place often at the Justice Center, for example, where individuals who were in jail, who need a competence to stand trial evaluation, a sanity evaluation, a mitigation evaluation, a sexual offender evaluation, any of those special evaluations, they're taken in custody to this court clinic, and then they're evaluated. There's also the forensic psychiatric hospital evaluation, where you come to a place such as where I work now, and you manage the treatment of individuals who, due to their mental illness, have been found incompetent to stand trial. During fellowship, you often also do private cases. And we're going to talk about all the different types of cases that forensic psychiatrists see. But an example would be someone who is having a fitness for duty evaluation. They might be a teacher or a police officer who is thought to have a mental illness, and questions are being raised as to whether they're fit for duty. If that question comes up, their employer can actually retain a forensic psychiatrist, including a forensic psychiatry fellow who's being supervised by a board certified forensic psychiatrist, to do that fitness for duty evaluation. That would be a private case. Or sometimes you have sanity cases where the defense private pays to have the sanity evaluation done, and that as well can be done during fellowship. There's a lot of didactics. And so the didactics are going to be lectures to teach you the law that you need to know in order to navigate the legal system. A lot of times we attend some law school classes. We also learn all of the different cases and case law that you need to know about forensic psychiatry. So you can understand Miranda warnings, so that you can understand the various pleas that defendants can enter, the insanity defense, the Constitution, how the United States Supreme Court has interpreted all the different mental health laws within the Constitution. And then there's mock trials. The mock trials can be intense, but they're extremely helpful to prepare you for the real world. Because as a forensic psychiatrist, you testify in court. When you do evaluations, you then write your report and you go testify. And the first time that you're cross-examined, you don't want that to happen in a real courtroom. You want it to happen with your fellowship director and with your attendings and people that are there to cross-examine you intensely, but then afterwards debrief you and help you to understand how you could have answered those questions better. And so the mock trial is an opportunity to have people poke holes in your opinion, or have you defend why you're saying that someone has a specific mental illness, or is competent, is not competent, is fit for duty, is not fit for duty. And so that's another component of the forensic psychiatry fellowship. And then there's more exams. At the beginning of fellowship, you do your adult psychiatry board exam. After fellowship, you do your forensic psychiatry board exam. Forensic psychiatrists tend to have two different types of cases that they deal with: treatment cases and evaluation cases. So I probably do about 80%, it can vary between 70 to 90, treatment. That's the competency restoration. And then the remainder are the evaluations. So let's talk about what each of those things mean. Treatment is going to be when you are treating people, you are managing their psychiatric illness in a context that involves the legal system. An example could be a diversion center. So there's all kinds of diversion centers across the United States where police, instead of arresting someone, can take them for emergent treatment. And those can often be staffed by forensic psychiatrists who help to treat the individuals who had been not arrested, but almost arrested and diverted because the police officers made a decision that what they were doing was stemming from their mental illness and that they needed that treatment and didn't arrest them. There's treatment in jails and prisons. So there's a large number of individuals with mental illness in the United States justice system. And regular psychiatrists, as well as forensic psychiatrists, provide treatment in those contexts. So they manage the depression, the anxiety, the psychosis of people that are in jail or in prison. There's outpatient treatment for individuals who are in the mental health system. Sometimes people are arrested, they are found guilty, and they're given mental health probation, where they are allowed to not be incarcerated and they're released into the community so that they can continue to go to work and live their lives, with the stipulation that they attend their treatment appointments, that they continue on their medications, that they check in with the probation officer, that they not use illicit substances. And that type of outpatient treatment is another realm that forensic psychiatrists can work in. There's competency restoration, which we've discussed. There's insanity equities. So when we talked briefly about sanity at the beginning, in those unusual cases where people are found not guilty by reason of insanity, they get committed usually to an inpatient psychiatric facility, and they then get treatment. And so that's another type of treatment. There's conditional release patients, where after someone has been conditionally released from the hospital, for example, they were an insanity equity, they've been there a couple of years, their mental illness is now in remission, there's no symptoms, and they're released, You could be the forensic psychiatrist providing treatment on the outside in the outpatient context. So for evaluation cases, you can really break it down into civil cases and criminal cases. With any of these, when you were the evaluator, you were there to be an explainer to the court, a professional explainer. In most cases, reports, at least in a large number of cases, are stipulated to. That means that you write in a report saying what you think someone's diagnosis is, what your opinion is on the legal question that you've been asked, and you submit that court report to the court. The attorneys agree to it, and then the court makes a decision. But in some cases, your job is to go to court and testify on direct examination, where you're asked questions to describe your opinion, and on cross-examination, where the opposing attorney tries to discredit you, show that you're biased, show that you're not experienced as an expert witness, show you that your opinion is unfounded. That's their job. And your job is to be there, not for a side, but for your opinion that you made, that you're painting a picture of what you saw and why you reached your conclusion for the court. So that's going to be the case in any of the evaluation contexts. Civil evaluations, there's lots of different types. Here are a couple of examples. Psychiatric disability. If someone has a psychiatric disability, which is keeping them from working, you could be asked to evaluate if they have that disability. For instance, they might have a workers' comp claim where they had gone to work, they'd been in a serious accident. For instance, they lost a couple of fingers as a result of malfunctioning equipment, and then they developed PTSD as a result of it. So you could be asked to evaluate their PTSD, how severe it is, and whether it was disabling to the point that they should be compensated by workers' compensation. You could do psychic damages with infliction of emotional distress, where you would evaluate whether someone had psychic damages. You could do fitness for duty, which we discussed a little bit earlier, and we'll do some hypotheticals in a second on. You could do malpractice. If another physician is being accused of malpractice, in many of these cases, they end up using an expert in the same specialty for the person, the plaintiff, who is suing the doctor, as well as the doctor for their own defense. And so that is another type of evaluation that forensic psychiatrists do. And there's testamentary capacity, which is looking at whether a will is valid or whether it should be invalidated because of the person's mental illness at the time that they signed their will. Let's look at a couple case examples. Fitness for duty. Let's say that you have a 32-year-old police officer, ex-military, has diagnosis of PTSD, not being treated, been really irritable at work lately. And last week, there were 2 occasions that he drew his weapon without any indication. He was startled, there were some kids there, took his weapon out, pointed it over in their direction with no apparent justification. Weapon taken from him, and he's told to report for a fitness for duty evaluation. Now, I haven't gone into a description of the legal criteria for fitness for duty, but go ahead and type in the chat, just hearing that, fit or unfit. Okay. So when you see these fact patterns, you make a gut response. And a lot of times that is going to be something that's going to impact you. But as a forensic psychiatrist, you have to stop, you have to step back, and you have to keep from having confirmation bias. You have to keep from having the bias of seeing things that support your initial opinion. And instead, you have to look at whatever the legal criteria is for the specific legal question that you were being asked, you have to review a lot of evidence. And then in your opinion, you have to line up each of the pieces of evidence and explain why they support your ultimate medical opinion. And as a forensic psychiatrist, your opinions are made based on a reasonable degree of medical certainty. Now take a guess in the chat. How sure do you think you need to be for reasonable medical certainty? Out of 100, what % surety do you think reasonable medical certainty is? I see 100%, 99%, keep going down, 90 to 95, keep going down, 50.1%. So the reason is because ultimately you are not the one that makes the decision. The court is the one that makes the decision. And so with these types of cases, they might have a higher burden. They might have a clear and convincing burden, which is closer to like 70, 75%. Not the reasonable doubt, which is like the 95, and that's just a guess because there's no actual bright line. But they want to hear your opinion as to whether it's more likely than not. And then they want you to support it. It is then up to the attorneys to try and show whether your opinion is right or not right. So in a fitness for duty evaluation, you're going to start by asking what your legal question is. Then you're going to review a large quantity of records. And the best bet is to get all of these records before you see the person, so that you have gone through their school records, their military records, all of their previous psychiatric history, all of their employment records with any grievance that's been filed against them the entire time that they have been there at the job. After you review all of that, you bring the individual in and you do the actual fitness for duty evaluation. At the start of that, you make sure to disclose to the person that it's not a typical treatment evaluation. Anything that is said can be put in that report that goes to their employer. It's not confidential. You ask them about their background history, their psychiatric history, their occupational history, what it's been like at work, any difficulties that they might have had. You do a mental status examination, asking them questions about memory. You give them words and ask them to recall them. You ask them about their mood. You describe their speech, how fast it is, what the tone is like, what the volume is like. You can ask them to describe proverbs, to name the current and previous 3, sometimes 5 United States presidents, series of cities, and so forth. And then you get collateral. So collateral is going to be important in any psychiatric examination, because people as human beings want to put their best face forward. So no matter what context you are asking people questions about, when you're talking about themselves, people don't like to talk bad about themselves. They don't like to think bad about themselves. So it's important to call their supervisor, to call their coworkers, to call their wife. You get their consent for this, at least for the family members and the non-employee ones. For the other employees, you typically go through the workplace to get their consent. And you ask them how things have been, what they've seen, any difficulties, the pattern. And based on all of this, you're going to make a decision as to whether there are current symptoms that make the person not fit for duty. So here we had the police officer with PTSD who's been very irritable, who's acting in a very sudden, jerky, responsive pattern. When you review the records, you see that he used to be on a very large dose of an antidepressant that is used to treat PTSD, and that he stopped going to the VA about 6-7 months ago and stopped filling his medications. So he's off of his medications. When you talk to his coworkers, you hear that he's been acting as if he was back in the war and that he's just been startled. When you talk to his wife, you find out that he's been drinking a lot lately. Every day when he gets home from work, starts drinking, continues going until 1 o'clock in the morning. So based on those facts right there and the drawing of the weapon, I would agree with what you said and what all of you stated in terms of him not being fit. But you would operationally define that by describing the current symptoms and how they impact his ability to engage in his job, his fitness for duty. You also look at whether this person can be fit with restrictions. For example, is it possible for him to have a desk job and not have a firearm? That would likely depend on whether he met criteria for a substance use disorder. If he did, then rehab would likely be required before he would be able to even return to work. If you say that someone is not fit, you give an opinion as to how long it is likely going to take them to become fit with appropriate treatment and what that treatment would be. So here, it sounds as if it would be returning to see a psychiatrist, going back on his antidepressant medication, going to all appointments, going to substance use treatment or otherwise abstaining from alcohol, and then being rechecked before returning to the force. Let's look at a malpractice case. 60-year-old man brought into the emergency room by police, depressed, hearing voices to kill his wife, on no medications, and a psychiatrist comes in. We'll call him Dr. A. Dr. A talks to the patient. The patient says, I don't know what they're talking about. I'm sad, but I would never kill my wife. This is all just a big misunderstanding. Dr. A is about to leave, tired, doesn't call the wife, doesn't call the police, doesn't review the paperwork, but sees that this person is an executive at a company, presents well, goes ahead and discharges him and tells him to go follow up with an outpatient psychiatrist in 2 weeks. Next morning, the gentleman kills his wife. So this would be a question of whether Dr. A deviated from the standard of care, and if so, whether that deviation caused the death of his wife. So those are the parts that the forensic psychiatrist asks, and those can then be translated into whether there was malpractice or not. So hearing these facts, did Dr. A commit malpractice? In the chat. You guys could type yes or no. All right, I see a lot of yeses. There's a definite possibility. All right, so one of the things is we're going to operationally define what you look at in this question. So we're not the ones that are ultimately deciding malpractice. We're offering opinions on components of it that the trier of fact, the judge or the jury, are going to use to make their decision. And in these types of cases, you have experts on both sides. So you have a forensic psychiatrist or a psychiatrist on the side of the doctor and on the side of the wife's estate. And both of them are going to come in and testify with opposing opinions. And it's the judge or jury that's going to offer the final decision as to whether there's a malpractice verdict or not. But as the forensic psychiatrist, what you're looking at is deviation and cause. Malpractice has 4 elements. It's the 4 Ds. Was there a duty? Yes. So there was a duty to hospitalize or obtain collateral, provide proper treatment. And given that there had been a specific threat against his wife, and that opens a whole dicey issue of threat of harm to others that we don't have time to go into, but there was a duty to provide proper care. Did he deviate from that duty by not hospitalizing the patient, by not getting collateral, by calling the police or the wife? If he did it directly cause the patient to then be able to leave and kill the wife? In other words, but for his deviation, would that bad outcome have happened? And were there damages? Okay. So in this case, it's a retrospective evaluation. What that means is, as the forensic psychiatrist, it's already done. It's happened. It's a year, sometimes a couple years later by the time that you get it. And what you get is a huge stack of records. You get all of the records from that hospitalization. You often get autopsy photos, you get autopsy reports, crime scene photos, depositions, sometimes you get interviews. But what you're really looking at is what happened before the guy left the hospital. Because hindsight is 20/20, and you want to avoid hindsight bias. The doctor, Dr. A, wasn't expected to act perfectly. He was expected to meet the standard of care, to act reasonably, like other psychiatrists would. And the forensic psychiatrist's job is to look at what he knew or what he should have known. And those are the vast majority of the records that you're looking at for whether there was a deviation from duty. The other part of it is more for assessing causation, whether that deviation led to the damages. So again, the question is deviation, which is, did their conduct, the psychiatrist's professional conduct, fall below the standard of care, and did it cause bad outcome? Here, you had the failure to get collateral information, the failure to hospitalize, and that then allowing the patient to be discharged and causing the death of the wife. Now, whether that caused a deviation, whether that was a deviation, and whether it caused the damages is going to be very factually specific. These cases are almost never black and white. It's going to depend on the details and exactly what was said, the context, the type of evaluation, how it was presented to him, what he was told, what he should have known. And that's how the forensic psychiatrist will make their assessment and give their opinion with a reasonable degree of medical certainty on the issues that they're being asked to give opinions on. Another type of retrospective evaluation is a testamentary capacity evaluation. So let's take the hypothetical of a testator, someone who's deceased now, who was 54 years old, had a $6 million estate, major depressive disorder, sometimes got some psychosis with his depression. So major depressive disorder with psychotic features. And that showed itself as him being paranoid about his family. A week before he died in a motor vehicle accident, he cut his family out of his will because he believed that his children had died and had been replaced by imposters. So after his death, the estate is one party, and then there's the family that were cut out of the will. And those family members can then sue to challenge the will. And they can hire, as can the estate, a forensic psychiatrist to give an opinion as to whether this person had the elements of testamentary capacity. Ultimately, it's a court decision, but the forensic psychiatrist offers an opinion on specific elements of testamentary capacity. And these elements vary by state, but in general, they consist of whether someone had sufficient mind and memory. So did they have a psychotic disorder, a paranoia, a depression, a dementia, and whether they had sufficient mind and memory to know that they're making a will, what is in their estate, who their heirs are, and their relation to their heirs. It's a retrospective evaluation again. So if this individual had been seeing a psychiatrist, primary care doctor, all of those records would go to the evaluator, as would the legal records with his initial will, his new will, depositions of all the family members who have given depositions. And based on this information, you would give an opinion on diagnosis, and then whether their disorder, so here the major depressive disorder with psychotic features, prevented them from knowing that they were making a will, what their estate was, who their heirs were, the relation of their family to them. So those are going to be 4 elements. So we'll call them 1, 2, 3, 4. In this particular case, which one do you think is going to be the most problematic that our testator would not have had? 1, 2, 3, or 4? I see someone saying 3 or 4. I see another 3 or 4. Okay, so everyone seems to be opining 3 or 4. So you could argue that. I would probably point to number 4 because he was able to hold the names and the identities of the people who were allegedly his children, but he thought that his children had already died and that they were now imposters. But I could see how the argument could potentially be made that it goes to 3. It was the fact that he thought psychotically that they were not his real children, and so that those individuals weren't his family. All right, let's talk about criminal evaluations. There's lots of different types of criminal evaluations. There's competence to stand trial. There is competence to be a witness. There is competence to get married. There's, but that's going to go into civil, but it's another competency. There's mitigation of sentencing. There's sanity at the time of the act. There's competence to be executed if you have been found guilty and sentenced to death. These are going to be some examples of criminal psychiatric evaluations. Let's look at another case example for competence to stand trial. 24-year-old man arrested for domestic violence. No past psychiatric history. He's in jail. He hasn't slept in a week. He's talking very fast, and he won't stay quiet in court. When you look at competence to stand trial, each jurisdiction is going to have its own specific competence to stand trial standard. So each state or the federal government, the District of Columbia, is going to have its own statute. But all of them are loosely modeled on an old case called Dusky. The one that I have here is actually the Ohio standard, and it's got 2 prongs. The first one is, does the individual have a present mental condition? If yes, does that make them incapable of understanding the nature and objective of the proceeding or assisting in their defense? Understanding the nature and objective of the proceeding is basically saying that you know what you've been charged with, you know who the various members of the courtroom are, you know the meanings of the pleas, guilty, not guilty, no contest, not guilty by reason of insanity, and you know that the American justice system is adversarial, prosecutor on one side, defense attorney on the other. The ability to assist in your defense is going to look more at whether you're able to coherently have discussions with your attorney, whether you're able to rationally have discussions with them. That's often not written into the statute, but it looks at things like whether you believe that your attorney is an attorney, or do you think that they are a government spy or part of the Illuminati, or part of a satanic cult, and they are attempting to work against you in order to send you to prison. Another thing that could affect your ability to assist in your defense is if you have very severe dementia and you can't pay attention during your own trial. You can't remember what's going on from one minute to the next. Those are going to all be examples of present mental conditions. So we're looking at the here and now that makes someone incompetent to stand trial. And the question comes about, if they're incompetent, that you have to answer is whether they're likely restorable. Can you provide treatment to make them better? If they're psychotic, probably. If they have a very severe dementia, not as likely, but still a question. In a competence to stand trial evaluation, you're going to look at the individual's medical and psychiatric records, their jail records, collateral reports. So that can be their school records if you're looking at intelligence, It can be statements from their family members if you're trying to decide whether they have a delusional disorder, and you're going to do an in-person interview. Full psychiatric evaluation, legal knowledge questions, questions about their attorney, what they think about the justice system. They don't have to know all the legal information, but they have to be able to learn it. So if they don't know the meaning of a no contest plea, that's okay. But once you teach them, they have to be capable of retaining it. And that's going to be part of the in-person interview. One of the questions that are asked in almost any forensic psychiatric evaluation, not the retrospective ones, so not testamentary capacity, not malpractice, but any of the ones that you're actually evaluating a person in person, is feigning. Sometimes people feign good. They want to be competent. They don't have a serious offense. They might have a really good case and want to be able to go back to court and not get placed in a psychiatric facility for treatment. And they might pretend to be all right to be found competent. Or they might fake bad. They might have a very, very serious charge, like an aggravated murder charge. They might be facing the death penalty. And in an attempt to avoid that consequence, they might fake intelligence deficits, memory impairments, a lack of legal knowledge, mania, depression, psychosis. And part of the forensic evaluation is assessing feigning. You look at their past records and you compare it to their current ones. You look at their behavior during your evaluation and you compare it to their behavior on the unit. You have a psychologist that comes in and does formalized psychological testing. Sometimes you can be asked to give an opinion as to malingering, which is drawing a connection between not just feigning, but saying that a person is specifically feigning to avoid criminal prosecution. In general, this tends to require an additional step and an additional layer of evidence. For instance, them telling nursing and other patients that they're not really hearing voices, that they're not really paranoid, and that they're just doing this because they don't want to go to prison. So that can be an opinion that is given in a forensic psychiatric evaluation, is a notation of malingering. So the opinion section lays out the legal criteria that we just discussed, whether they have a present mental condition. If so, what symptoms from that condition are currently active that make them unable to understand the nature and objective of the proceeding? Intellectual disability, making it so that they can't understand the various plays, or an inability to assist in their defense. Psychosis, making it so that they can't work with their attorney. And then the issue of whether they can be restored within the time period allowed under the statute. This gentleman that we looked at with the case example, he's not sleeping for a week, he's talking really fast, he's not staying quiet in the courtroom, would keep him from working with his attorney. They couldn't have a coherent, productive conversation. He wouldn't be able to sit through court. Again, the details are what matter, so we would need to look at the details, but at first glance, those facts seem to indicate that he is incompetent. A sanity case is another one that is done for a criminal evaluation. Take the example of a 23-year-old woman arrested for the murder of her 4-year-old son on New Year's Eve, no past psych history, in the jail, diagnosed with schizophrenia. This was her first break. Now she's on antipsychotic medications, doing better, very, very remorseful, very sad as she's realizing what happened. And you learn during the evaluation that she killed her son because she believed that he was going to be tortured and dismembered and then killed on New Year's Day. And that she killed him in what she considered to be a humane way because she viewed it as the right thing to do to save him. So this is the type of case that could then be put forth for a not guilty by reason of insanity plea. And if she was adjudicated not guilty by reason of insanity, that could result to her ending up in a psychiatric hospital as opposed to a prison. So the legal criteria for sanity is going to be looking at whether at the time of the offense, they have a severe mental disease or defect. And if so, whether that caused them to not know the wrongfulness of their act. Now, this is the Ohio statute version. Each jurisdiction can have different ones, and there's 3 or 4 strains of insanity defenses, but that would be a lecture all on its own. But in general, the vast majority involves some component of wrongfulness. The evaluation is similar to the competence evaluation in terms of records, but it also looks a lot more at the data from the offense. You look at the autopsy photos and you look at how it was done. You look at the crime scene photos. You look at all of the police reports, the 911 calls, all of the information. You review it in order to figure out whether the facts at that time match with her having been psychotic and not knowing that what she did was wrong. If she tried to conceal the body, if she tried to wipe up the evidence, she tried to escape and evade the police. Those would all be things that would point against, they wouldn't mean she couldn't have one, but they would point against an insanity defense. If instead she called the police and she told them that she had saved her son, where the body was, if she had been doing searches in terms of the most humane way to kill someone, if she had been doing searches about how to protect her son, all of those facts, and that's data that you review, including phone records, text messages, they could be used in your opinion to support your insanity opinion. There's also the evaluation of the defendant, where you do the full psychiatric evaluation. You take a detailed account of the offense. You ask them to describe what they were thinking, what symptoms they were experiencing before, during, after, exactly what they did, and you put that into your opinion as well. Your opinion has the diagnosis and whether the symptoms of that diagnosis led them to not know the wrongfulness. So here, there was the delusional belief that he was going to be dismembered. The delusion is part of the schizophrenia. And then depending on what was said during the evaluation, that could definitely support her not knowing that what she did was wrong. All right, so if you're interested in forensic psychiatry, once you get to medical school, well, even before you get to medical school, you can take a look at the organization, American Academy of Psychiatry and the Law. It's called APPLE. And they have an awesome newsletter, an awesome journal that comes out every single month. It's all free online. And I don't think it comes out every month, maybe it's every quarter, but there's a number of journals that come out throughout the year. And they have super interesting articles that you can start reading. Then once you get to medical school, you can shadow forensic psychiatrists. You can get involved in writing articles and watching cases and doing presentations. You can go to the Apple meetings and the conferences. There's med student rates. And then when you match, you can look at psychiatry residencies that have forensic psychiatry fellowships that you could have met at some of the conferences and talked with them. And that would allow you to pursue this subspecialty career path. All right, I see some questions coming up in the chat, so let me go through them. First up, I see the question of, do you work much with other medical specialties? Yes, somewhat. I would say personally, for me, the one that I tend to work the most with is going to be the internal medicine doctor that is on site at our facility. Now, remember, forensic psychiatrists can have very different types of jobs. There are some who do predominantly non-forensic psychiatry, and then a day or two a week do forensic psychiatry cases. There are others that are at correctional facilities and they do correctional psychiatry. There are some that work at court psychiatric clinics and do predominantly evaluations for criminal cases. So it's going to really depend on where they are. For me, doing competency evaluations and restoration, I work with internal medicine doctors who help to do the history and the physical, manage acute medical issues, control the diabetes, asthma, and other things along those lines. A forensic psychiatrist who's working in an emergency room, doing violence risk assessments, triaging who requires admission and who doesn't, could be working with the emergency room physicians, the surgeons, the internal medicine physicians. So it's really going to vary. And then I saw the question of, do malpractice cases always involve criminal outcomes? So no, malpractice cases do not always involve criminal outcomes. So a malpractice case could involve prescribing a medication. For instance, let's say someone prescribed Lamictal, which is an anti-epileptic that can be used for mood stabilization in bipolar disorder, that you have to slowly titrate to avoid or reduce the risk of Stevens-Johnson syndrome. Let's say that a psychiatrist prescribed it at the max dose right out the gate, and they did not do the titration. They didn't give informed consent or discuss the issue with the patient. Patient developed Stevens-Johnson syndrome rash and got permanently disfigured. That would be a malpractice case where the opinion could be whether they deviated from the standard of care by not appropriately titrating the dosage. Next question that I see is, what if the defendant refuses to participate in a court-ordered evaluation? Do you still make a finding? So that's an interesting one, and it's going to really depend on the context. The answer is yes, but it depends on the details. If you look at a competence to stand trial evaluation, there are many individuals who are at the jail who are referred for a competence to stand trial evaluation, either by their attorney, the prosecutor, or the judge. And they might then decline to participate in the evaluation and go to the court psychiatric clinic or go to the room in the jail where the evaluator is, or wherever it might be taking place. Now the question comes up then, why are they refusing? Are they refusing because they just don't want to do it and they disagree with it? Or are they refusing because they're paranoid and there's some psychosis there where they're scared and they're afraid to do it? So in Ohio, as well as many other states, there's a mechanism for courts to order an individual to an inpatient psychiatric facility, like the one that I work at, for an inpatient competence to stand trial evaluation. So they can't withhold consent, and they have to go to the evaluation because it results in them being transferred to the hospital. Oftentimes, once they're at the hospital, it's a therapeutic milieu, there's other patients, there's nurses, there's therapeutic patient workers, social workers, people that are used to assisting with mental illness. So a lot of times once they're there, they'll sit down and they'll partake in the evaluation. If they continue to decline to do that, then the evaluation itself will be built upon the records from the jail, as well as observations of the individual on the unit, seeing how they interact with their peers during meal times. And in our state, we have up to 20 days to then make that assessment based on those observations. Next question that I see is, do most people in your field have a background in law? No. So, you do not need a JD in order to go into forensic psychiatry. I found my way into forensic psychiatry, and I think that my law background is probably part of what piqued my interest. But the vast majority of individuals in forensic psychiatry do not have a law background. And you don't need one, because the fellowship training is so good in terms of the knowledge of the law that you were taught, that you get what you need through the mock trials, through the didactics, in order to do your job. I find mine helpful, but I think that the learning curve was more just a little different as a result of my having the law background. And within 6 months of being into our fellowship, we were all on much more even footing because of those didactics and the teaching that you get in the law. Next question that I see is, do I mainly spend my day-to-day work at the hospital? And how much time would a forensic psychiatrist spend in a courtroom type setting? So all of my time is in the hospital. Now, part of that is because at the moment, hearings are via Zoom. And so we don't go to the courthouse. The courthouse is set up on the first floor where there's a Zoom camera that is brought in, or for some cases, like civil commitment cases, the attorneys as well as the magistrate end up coming into the courtroom that is there in the hospital. But even that is not that frequent. I would say that I submit somewhere between 1 to 5, maybe average of 3, 1 to 3 reports in a week. Sometimes there's weeks I don't submit any, but I write a lot of reports. I only testify maybe once a month, once every other month. So the number of times that I end up going to a hearing, which due to Zoom is there at the hospital in our courtroom, is not that frequent. Oh, I saw someone put the Apple link up. Thank you. That is exactly the right one. Next question is, would you recommend psychiatry to someone who would like work-life balance, even if not forensics? Yes. So psychiatry in general is a very family-friendly field. I remember when I went to my residency interviews, my program director had pictures of her kids on the door. So psychiatry is a specialty that allows you to balance work and whatever aspects of life are important to you. Next question I see is, what is a common misconception of forensic psychiatry? I think that it's a subspecialty that a lot of people don't know about. In some programs, there's a lot of forensic psychiatry. So there's a couple areas in the country where there is a very high concentration of forensic psychiatrists. And in those programs, through residency, you're going to learn about it. Even in medical school, you're going to learn about it. But in many places, you don't know it exists. And so asking what the misconception is difficult because there's a lack of recognition of the existence of the subspecialty. And that's something that I think is good to draw attention to because it's such a unique niche. What do I love about what I do? I think I love the diversity of my days and of my work. Every single day is different. And I have this great mix of having on a daily basis both the evaluations and the treatment, which means that with my treatment cases, I'm getting to watch people get better, providing them with treatment, helping their psychosis, their depression to resolve or at least improve. With my evaluation cases, I'm spending hours reviewing massive amounts of records, thinking through the case, laying it out and outlining it, trying to support my opinion. And it's really a very fun intellectual exercise because each case is so different. And you want to make sure that you don't just make your opinion, but you support it with the data to show why your opinion is one that you hold. And so that ability to do both the treatment and the evaluations, to work at a place where it's a very collegial environment and everyone works together very well, and where I have 40 hours of work a week. And it's a state facility, which means that when I leave for the day, I don't take work home because it's all secured there on site. The electronic medical record is not one that I can access from home. So when I clock out at 4:30 and I come home to my family, I'm done for the day. And all of those different aspects are why I really enjoy my job, and it's the perfect fit for me. What type of case do you find the most interesting, or what do you like most? I think every case is interesting. I think every case has components that you can delve deeper into and that you can really look at from different angles. So given that all of my cases now are competency, it's going to be a case by case looking at the diagnosis and the specifics of it. During fellowship, when I was doing all of those different types of cases that I discussed, I would say the type that I found the most interesting were the sanity cases. I found some of the crime scene photos, the autopsy ones, I found those to be a little bit more difficult because a lot of them can be very detailed. However, the cases themselves had a lot of information. It required a lot of thought, and I found those to be the most unique. Before you started med school, were you aware of the field, or did you learn about it while in med school? Right, so I did not learn about the field until I was in med school. I was in, I think it was my third year of med school, doing a regular psychiatry rotation. It wasn't a forensic psychiatry rotation. And I was sitting there staffing with an attending who was covering for a different attending. And her and I started chatting, and I learned that she was a forensic psychiatrist. I didn't even know that the field existed. She told me what it was, and she explained how I could get an elective in it. I called my advisor. I got an elective in forensic psychiatry. During my elective, I was given probably this much information to go read the first night. So I went home, I read all of these cases, I read all of these pamphlets, and I was so intrigued, and it was so interesting. And that kind of started me down the path. And then this was the year that the American Academy of Psychiatry and the Laws Conference was in Fort Lauderdale. And one of my mentors, new mentors, said, hey, you should go to this conference that's being held in Fort Lauderdale. I went to it and I was sold. I knew that that's what I wanted to be. How do you keep yourself sane? So, I mean, I think the fact that it's a 40-hour work week and that my work is kept at work and my home is separate really allows me to turn it off when I come home. I do stuff, right? Like I write articles, I teach, I do presentations like this, but it's not the core work. I exercise a lot. And I think all of those things, together with the fact that, again, I have nights and weekends off, allow me to maintain mental stability and to have a good work-life balance. Are there any particular things you enjoy doing outside of medicine? I did scuba diving, I did skydiving, snow skiing. I still snow ski some. I like to kayak, but I would definitely say that it's not the work that has taken me away from a lot of those extracurricular activities. What is the most disturbing case you have come across that you can talk about legally? And being mindful of their privacy and HIPAA. So I think the category of cases involving parents killing children would be the category of cases that I find the most difficult. For someone that is interested in policy and medicine, like you were at the beginning of your medical journey, would you recommend going the JD-MD program route? How necessary would you consider it? So that's a question that I've seen debated many times. There are Facebook groups with psychiatrists, and that's a question that I've seen there. It's going to really depend on how you're going to leverage the JD. If you're looking at going into policymaking, in general, you don't really need it. You're going to get the information that you need from medicine, and then they have various master's programs that can assist you with the policy aspect. So that's what I was initially interested in, but that was more because of what I saw during my work as an attorney, as opposed to the JD being fundamental to my desire to go into that. What do you find most difficult in your job, or what do you like the least? I think sometimes it can be intense when you have people that are very, very ill and they first get there, and you're trying to balance the desire to manage the safety of your staff as well as yourself against their mental health needs. Trying to manage that is a delicate balance, and that can sometimes be difficult. And I wish that that was easier, but again, we're very fortunate to have great teams that work together and that are very good at de-escalation techniques. But that aspect of it would probably be the most difficult. Do you struggle to be compassionate with your patients who have committed crimes? I don't. And it's interesting because I don't view people as having committed the crime that they're there for allegedly committing. because you never know what evidence there might be. Anyone that comes in for a competence to stand trial evaluation, they've allegedly committed it. They've been indicted, which means that a grand jury has seen enough to start the proceedings. But they could have an alibi witness. They could have some wonderful evidence that they haven't had the opportunity to present. And people have a right in our American justice system to fight their case and to go to take it through the legal justice system and to be presumed innocent until proven guilty. So I don't really think through those dynamics, but that perception is probably part of what allows me to see the individuals that I work with as patients, as opposed to people who have been accused of committing a crime. How often do you experience malingering? So that's difficult because my sample base for the evaluations, many of those are specifically sent the inpatient competence to stand trial evaluations as a result of concerns of malingering. So the inpatient evaluations tend to either be people who refuse to go in for the evaluation, people who were malingering, or people who were so ill that the evaluator had concern that they were malingering, but it was really just very prominent untreated psychosis. So given that those are the cases that I see for the inpatient evaluations, the percentage of malingering, first off, it's going to vary from week to week and month to month. But the numbers that I get, and I would have to look at my case log, they're going to be higher than the actual percentage because I have a skewed sample. If not psych, what specialty do you think you would have gone into? You know, I don't know, because I actually went through third year not liking the specialties that I went into up until psych. A lot of people will go through their third year rotations loving everything and having difficulty deciding which one they want to go into. I went through them and I was like, I don't enjoy these things. They're wonderful to learn. I'm very grateful to have the opportunity, but it's not what I want to do. And I didn't feel like I fit in with the people in those other specialties. And then I got into psychiatry, and even just general psychiatrists, without even looking at the subspecialties, I felt like I fit in with them. And I felt really enamored by the work. And it was something that I really enjoyed. And then learning about forensic psychiatry helped that even more. So I don't have an answer on that. Since you worked for Kaplan, do you have any advice for students planning on taking the MCAT or other important standardized tests? Yes, my advice would be to make sure that you go to some sort of preparatory course or book or some sort of intensive review, and that you do a lot of practice tests. Many people look at the questions and they think that they don't need to do the practice test to the same extent. The practice test is going to be just an absolutely imperative aspect. It's going to help you to gauge how you were doing, to look at your weaknesses, to really mitigate those weaknesses, and focus on remediating any knowledge deficits that you have. So questions are imperative. All right, do we have any other questions?
I do have a question. It looks like we do have a question here. I read everywhere that fitness for duty evaluation have caused racial disparity in police hiring. Would you say that your field has become aware of this and why it's happened?
So that's a good question. And I haven't heard any particular work within the forensic psychiatry community. It could be there, I'm just not familiar with it, looking at the racial disparities in the fitness for duty evaluations. Racial disparities in general is definitely something that has been looked at. And there are various task force and work groups that are looking at both the data and how we can address this as a field. But narrowing it down to fitness for duty, I'm not familiar with that particular niche of it being looked at.
Thank you. And then I got a personal DM question. Do you have any podcasts that you recommend?
I don't. I don't really listen to podcasts. I know there are some very interesting ones, the names are not coming to mind, that have actually followed forensic psychiatry issues and cases, but I don't have the name offhand.
Awesome. Well, thank you so much for joining us today. I'm going to go ahead and for the students who are interested in getting a certificate that verifies your shadowing hours with us today, I'll go ahead and give a brief presentation. But before we get into that, I just wanted to thank you so much for your insight, your time, and just the amazing talk that you've given us today.
Thank you. Thank you. It was a pleasure to be here. And if anyone has any questions, I'm going to put my email in the chat. You are more than welcome to email me with any additional questions that you might have.
Thank you so much. And this is a thing for our asynchronous students. So if you're watching this asynchronously, this is a perk of joining us at the live sessions. Oftentimes our professionals will give their email in the chat to students who attend our live sessions. And so if you're interested in connecting closer with our professionals, I encourage you to check out our live sessions, but of course we will always post our sessions asynchronously to be completed on our website. So we'll go ahead and hop into this wrap-up presentation. And so before we get into it, I just want to take a moment to open space for reflection. I want to get the brain juices flowing. You know, what brought you to today's session? What are 3 major takeaways that you got from this presentation? And what do you want to learn more about? Of course, you don't have to share this. This is completely for you, yourself, and your growth. But if you are interested in sharing this, you can submit your work to the pre-health shadowing blog submissions page on our website to be featured. You can submit articles, reflections, reviews, or success stories focused on pre-health shadowing. And so if you're interested, I encourage you to check that out. If you are interested also in being a part of the pre-health shadowing team, we are opening up internships for the upcoming summer year. You can apply on our website, prehealthshadowing.com/join our team, as well as volunteer. Some perks about working with pre-health shadowing is that you get to work 100% remotely and on your own time. And so if you are really busy, you got a lot of things going on, or maybe you or one of your family members is at risk for COVID or at higher risk, pre-health shadowing is a great opportunity to still get involved in the community while taking those precautions. And so feel free. We'll stick around at the end if you have any questions about joining the team or our upcoming opportunities. And another thing is if you can donate, we do ask you to do so by scanning this QR code. It'll take you to our donation page. Pre-health shadowing is a flexible and accessible program started by students. It's a federally recognized nonprofit organization that is recognized by the AAMC. And we are working to fight inequity in health education and promote diversity in the various healthcare fields. And so please help us keep our platform free for everyone all over the world by donating. If you're financially unable to donate at this time, we please ask that you forward this link, either post it on your social media or send it to members of your community, family, and friends so that we can support our mission. All right, now to get to the certificate portion. So if you're interested in getting a certificate that verifies your virtual shadowing hours with us today, you will go to the pre-health shadowing website, prehealthshadowing.com, and make sure that you are signed up for the course with our professional today. You will have 30 minutes with a 10-question post-shadowing assessment. You'll be granted 2 chances to pass with a 70% or higher. And upon passing, you will be granted a certificate that has your name, the date of completion, as well as the professional's name and the number of hours that you've completed. All of our shadowing hours are verifiable and recognized by a majority of various programs. Of course, if you are interested in noting which schools regard pre-health shadowing as a credible alternative to in-person shadowing, we do always recommend that you reach out to the admissions committee of that particular program. However, we are speaking with various programs, and so if you are interested, definitely reach out to them. If you missed any part of today's session, you can visit our website or YouTube channel, prehealthshadowing.com, to watch this session or any of our previous sessions for free. Be sure to catch our sessions every week. We are always hosting new professionals with different insight, different backgrounds, and different jobs and specialties. You can check us out on our website and on our social media. We are on TikTok, Facebook, and Instagram at Pre-Health Shadowing. And if you have any professionals that you are personally interested in shadowing and would like to invite them to Pre-Health Shadowing, you can sign up to be a volunteer and help us with professional outreach. Or you can also nominate them on our website, prehealthshadowing.com. That is all for today. This marks the end of the shadowing session. Feel free to disconnect from the Zoom. If you have any questions for our student team, we'll go ahead and stick around for a few extra minutes. If not, I hope you have a lovely rest of your week, and we hope to see you at the next session. Bye, everyone.